everyone, and welcome back to our channel. If you're new to our channel, my name's Caitlin, this is my lovely friend Abby, and we are
the Roentgen Girls. We give you the rundown on everything there is to know about radiology.
This week's topic, Trauma 101.
Throughout this video, we will be discussing what trauma is, what are clinical indications of trauma, some pathology, positioning tips and tricks, communication, and other things to know.
First off, what even is trauma?
Physical trauma is a serious injury or a shock to the body. There are two types of physical trauma, penetrating and blunt force. Blunt force trauma occurs when an object or a force strikes the body. Penetrating trauma occurs when an object pierces the skin. Trauma from a radiology standpoint is a serious injury or shock to the body, often requiring modifications that may include variations in positioning, minimal movement of body parts, and critical thinking. Now that we know what trauma is, how does it pertain to radiology?
As a technologist, we should obtain diagnostic images, give exceptional patient care, abide by radiation protection for ourselves, our patients, and those around you, and providing professional and necessary communication.
Common trauma injuries would include bleeding, punctured collapsed lung, broken bone, etc. These injuries can be from a result of a fall, a vehicular crash, a work-related injury, sports injury, and many more.
There are two types of fractures: a simple or closed fracture, which is when the bone breaks but remains within the body, and a compound fracture, where the bone is broken and breaks through the skin's surface. Two fun types of fractures that you will see in a clinical setting are spiral and compression fractures. A spiral fracture is when a ragged break occurs when excessive twisting force happens. This is common with a sports injury. A compression fracture is when the bone is crushed.
First and foremost, communication is the most important aspect of trauma. Whether you are communicating with the patient, the family, or other healthcare professionals, it is important that everyone is aware of what is going on. Treat this exam like any other exam in terms of patient care and communication. Introduce yourself. Double ID the patient. Verify the orders with your patient. Hey, we're taking a chest x-ray today. And obtain a history. If the patient is unconscious or sedated, they're not able to do so, so make sure you verify with the doctor or nurse and check their wristband. You also want to explain what's happening. You want to be fast, efficient, but that doesn't mean you need to neglect patient care. Tell them there's a cold hard board going behind you, or we're going to move this, change that. Give them breathing instructions if they're conscious. If they're not conscious, make sure you just watch their breathing. A big part of trauma and radiologic imaging in general is communicating with the physicians and the radiologists. Just because it is trauma does not mean that you need to just do the exams that are ordered. If at any point in time you are confused about the order or you don't think that the order is necessary, it is your duty as the radiation safety enforcer to clarify and avoid any radiation exposure that is unnecessary. Make sure that you are using the utmost professionalism when you're doing so. Communication also comes into play when charging the exam to the computer. Since the radiologist is not in direct contact with the patient, you are their eyes and ears. Rule of thumb is document, document, document. Annotate all pertinent information in the image as well as document in the notes what you've seen, heard, what the patient could do, what they couldn't do. These are all very important when making a diagnosis. In all, make sure that you are communicating, especially in trauma situations.
When a trauma comes into the hospital, it can seem chaotic and overwhelming. As radiologic technologists, we need to be able to adapt to any situation and get the information that the doctor requests in an efficient manner. It is important to remember that trauma positioning will never be textbook. Critical thinking and problem-solving skills are needed to obtain the projections. Of course, like most things, there are rules to every trauma.
Rule number 1, do no additional harm to the patient. Rule 2, obtain 2 projections 90 degrees from each other. And finally, include all pertinent joint spaces and injured anatomy. You just get the page that a level 1 trauma is being transferred to your ER. What do you do? When a patient comes into the ER, a physician will most likely order an x-ray of the chest, abdomen, and pelvis. This is to rule out immediate and serious trauma like a punctured lung, bleeding, or a broken pelvis. When the patient is triaged, they may go through CT to get an in-depth look at the extent of their injuries. Keep in mind, some trauma room beds may have a pocket to slide the image receptor in, while others will require the patient be moved in order to slide the board underneath them.
One of the first things that they order is a chest x-ray to evaluate the lung field and ensure no damage is done, such as pneumothorax, hemothorax, etc. In this case, we were able to sit the patient up straight, so you see us introducing ourselves like normal, raising the bed so that they're sitting up as far as they can. We place the image receptor behind them, let them know that a cold hard board is going behind them. We angle the tube, make sure everything is out of the way, possible snaps, anything like that, and we take the picture. For optimal imaging, you would like the patient to sit as straight as possible. There will be times where you cannot sit them up and they will have to lay flat. Bring the portable tube over the patient and angle caudally 3 to 5 degrees so that the CR is perpendicular to the sternum. If the patient is able to follow breathing instructions, have them take a breath in and hold it. If not, watch their breathing, and once they are on a full inspiration, expose. Chest x-rays are one of the few trauma exams where you will only be doing one projection.
A patient comes with an injury to his or her lower leg. You notice that there is an open fracture of the distal tibia. In this case, we want 2 projections 90 degrees from each other. Whether you are doing this exam portably or in the department, you still need to ensure that you are moving the patient as little as possible. Stop. Always put gloves on before working in a trauma. As you can see here, one tech is responsible for placing the cassette and the other is responsible for support of the body part. To ensure the most support, it is important that one hand is positioned by the knee and the other is positioned by the ankle. On the count of 3, the leg is lifted in one slow, swift motion. Because of the hand placement, this ensures no movement of the fracture site and the leg is supported at all times. Be sure to include both joint spaces and correctly mark the anatomy with a lead marker. For the lateral projection, we will be using a horizontal beam or cross-table projection. For this, we will place the cassette between the legs and, if available, carefully place the leg on a radiolucent sponge or use what you have available to you.
A patient comes into the ER with an obvious ankle deformity. Since we need 2 projections 90 degrees from each other and cannot move the ankle for a normal routine image, what do we do? In order to place the image receptor under the leg for an AP projection, you need to support the leg and carefully, with one hand supporting the mid-lower leg and one supporting the ankle, lift up while the other tech slides the image receptor under the leg. Make sure all anatomy is included and mark correctly. To obtain a lateral projection, you should perform a cross table. In other words, we will be using a horizontal beam in a lateral medial projection. In some cases, you can build up the ankle to ensure no anatomy is clipped. You can do this by using a radiolucent sponge if available, otherwise use what's around you. In this case, we used a bed sheet to raise up the ankle. It is important to note that in some cases, you cannot raise up the ankle.
As we just learned, trauma patients will require special care when transferring or moving. As we have already stated, we should not cause additional harm to the patient and follow the lead of the physician. Here are some basic transfer or moving techniques that you will use during a trauma. First off, our most common that you will use during a trauma is a slider board transfer. This usually involves at least 3 people. One person is sliding the patient onto the table, one person is helping roll, and one person is stabilizing the C-spine. As you can see, they all work together in one swift motion. On the count of 3, the patient is slid over onto the x-ray table. Note that the tech who is holding the C-spine is stabilizing the C-spine to ensure that no unnecessary movement of the head and neck happens, preventing any additional harm to the patient. She moves with the patient, holding their neck stable as the other 2 techs transfer the patient from the cart to the table. Sometimes your patient won't come down in a bed or a stretcher. Instead, they'll come down in a wheelchair. Notice that these two techs both have a grip under the patient's arm as they slowly allow her to pivot onto the x-ray table without moving or putting pressure on her injured leg.
We've covered an immense amount of information today, and trauma can seem very overwhelming at first, but it's crucial to know as you will encounter it as a technologist.
We hope that you guys took away some helpful tips and tricks that will help you in the future so that you are more prepared for when the time comes.
As for us, we hope you have a wonderful day.
Hope to see you next time. Bye!